So this is the first example is our AVNRT. So here again I said this is a short RP tachycardia. If you can pay some attention, the P wave is somewhere here. It is somewhere near the QRS. It's so near to the QRS. So you can see it in lead V1. So that's what is called as a pseudo R pattern. The rate is regular at 150 to 250. The onset is sudden. That's why it's paroxysmal. There are other forms are there, fast, slow and slow intermediate. These are atypical variants of AVNRT, but the more common variety is the slow fast one. Again, this is another example of AVNRT. We can see a small pseudo R there, just next to the R wave. So again, this is also another example of AVNRT. This is an example of AVRT. Again, AVRT is also short RP tachycardia. The retrograde, the conduction backwards is through the axillary pathway, antegrade is through the His-Purkinje system. So you have an narrow QRS, but then you can see probably a P wave slightly on the ST segment rather than on the you can see some deflections on the ST segment in the lead V1. So that differentiates an AVNRT from AVRT. It's not always possible. But then there is some association. AVNRT is usually not associated with any congenital anomaly, but AVRT is associated with Epstein's anomaly. And then the onset is sudden, childhood incidence is there. In fact, the tachycardia rates can be quite extreme sometimes. And it's also a regular tachycardia with a rate of 150 to 200. Here again, another case of AVRT, you can see a small, you can see the distortion in the T wave, especially in this complex. So the P wave is slightly delayed as compared to your AVNRT, but then you can see it's a regular tachycardia, a rate of around 180. Atrial tachycardia, again it depends on the site. So we have a slightly, now this P wave is clearly seen here, and we can see the R to P is quite far. The R to P is more than the P to R. So this is a long RP tachycardia, but we can see an inverted sort of P wave. So this is coming from a different focus other than the sinus. And you can also see an AV delay. So this is your atrial tachycardia. And again here another case of atrial tachycardia is there. Here you can see a morphologically different P wave you can see a positive P wave in AVR. So that's indicating a left origin, and usually you see a negative P wave. So and then you have a slight PR. So this is atrial tachycardias are sometimes associated with cardiac and pulmonary disease. They are little stubborn to treat. And sometimes you may have to give several antiarrhythmic agents to control their rate, and sometimes you may have to subject them to a quick EP procedure also. So again, the onset could be sudden, rate is around 150 to 250, and it's regular tachycardia. Junctional tachycardia. Junctional tachycardia refers, you see, the junction is that part of the conduction system that actually connects the atrium to the ventricle. So you have some kind of ventricular activation as well as atrial activation. Compared to the previous example, you can see that you can see some inverted P sort of waves here. But then what differentiates this essentially from atrial tachycardia is the PR would be very, very short. It will be almost falling on the QRS, because at the same time the impulse is going to the atrium and the ventricle. There's almost a simultaneous activation. Again, junctional tachycardia has got some pathology associated with it. So digoxin toxicity, ischemia, myocarditis, post-op cases, post-op congenital heart diseases, inotrope use, and also some kind of sinus node dysfunction would be there when junctional tachycardia is there. Sometimes we have this ectopic junctional rhythm. So where the junction is able to capture sometimes it is not able to. Sometimes the P wave from the native thing is able to conduct. So you will have variable appearance. So this is a case where you can see the first three are sinus conducted beats, then these are junctional beats. Here you have a funny looking ECG. You have some P waves. This QRS likely a sinus conducted. This is a junction ectopic. This is again a junction ectopic. So it is possible to have this is again a sinus conducted thing. This is sinus conducted. So the junction might accelerate in response to injury or some congenital conditions. So these rhythms again are little stubborn to treat, and they may respond to amiodarone, but also if they are difficult to control, we may need to do an ablative procedure. Atrial fibrillation, the most common arrhythmia that we see in our ICUs, associated with pulmonary disease, sepsis, thyroid conditions. So the rate and also post-op, the rates are between 110 to 220. It's irregular, sudden or gradual in onset. So this is a typical atrial fibrillation. The most cardinal feature is a irregular rhythm. And atrial flutter, again a stubborn arrhythmia. We have difficulty in To controlling this, it's quite frequently we need to use several antiarrhythmics. We may have to cardiovert these rhythms also. It can be regular or irregular. The reason is if you have a fixed conduction, say 2:1, you will have a rate of 150. If it is getting blocked with some AV nodal blocking agent, it may vary from between 75 to 150 to 220. So it might vary as per the AV node behavior. So multiform atrial tachycardia, again a common association with COPD and people on theophylline therapy. So you will see varying morphologies of P waves. Like you can see in all these things, you see different morphologies of P waves. You see a irregular rhythm. You see RR interval is not stable. So this is again not very treatable, but then it's not a very big problem also, because the heart rates are typically between 100 and 150. We have to manage the primary lung condition only with this. So sometimes you have to unmask these P waves. You cannot see them on your regular ECG. You may have to use the Lewis lead. The Lewis lead is nothing but a repositioning of the leads just to bring out the atrial activity. So you put the RA on the manubrium, and that is the right arm on the manubrium, left arm on the lower border of the sternum on the right side. The lower limb will be on the left lower right lower sternal rib cage, and the right limb will be in its own the LL is left limb, sorry. The left limb will be on the right lower lip cage, and the right limb will be on its position. So the point is, this is once, and with this lead position you see in leads 1 and 3, then you will be able to make out these P waves, and then you can see that you also might want to increase the speed to 50 millimeters per second and amplitude to 20 millimeters per millivolt. You will be able to see these hidden P waves and all these things.